Hello, welcome to WeNAP, Webster Nurse Anesthesia Podcast. My name is Michael Burns. I'm a professor at Webster University in St. Louis, Missouri. Today, we're going to talk about peripheral nerve blocks. I'd like to welcome all of my students at Webster University and also all the Cameroonian nurse anesthetists back in Cameroon. This is part of the project my students are doing for research. I greatly appreciate your participation in their study, and I look forward to seeing you guys in December of 2022. Just to tell you a little bit about myself, I've been a CRNA for 22 years. Most of my research and practice is surrounding acute pain management and the placement of peripheral nerve blocks, as well as I was a director of anesthesia for 20 years or so prior to committing to full-time professor position. I'm again very thankful for you guys' participation in the study, and I look forward to advancing with you guys our learning of peripheral nerve blocks. So let's go ahead and get started. Some of the topics we're going to discuss today is the benefits of peripheral nerve blocks, basic block safety, a little bit about pharmacology of our local anesthetics. And anytime you mention local anesthetics and pharmacology, peripheral nerve blocks, you think of large boluses of local anesthetics. We have to talk about LAST, which is local anesthetics systemic toxicity. We'll talk a little bit about nerve anatomy, some techniques that involve nerve stimulation, maybe a little bit about ultrasound, some needles, the various different types that it's available. And specifically, my three students, Farah, Sandra, and Jennifer, they're really going to focus on their presentations on axillary, peripheral nerve blocks, femoral, and popliteal. But I'm going to introduce those types of peripheral nerve blocks, which I think for this project, I think we'd like to just concentrate on three. They certainly could have some utility in Cameroon and certainly other practices within worldwide. But for this purpose, we're really going to concentrate on these three blocks later in the presentation and really think of stimulation technique with some ultrasound. The availability of ultrasound could be not as reliable as in the US. So stimulation technique will be, even some palpation techniques will be discussed as well. So what is the benefit of a peripheral nerve block? So, why do we want to go through this process with our patients? And basically to avoid general anesthesia, especially I just did one this week. Patient had a history of malignant hyperthermia, had a fracture of their radius, and we wanted to perform the surgical procedure without general anesthesia. Unfortunately for the patient, she also had a history of ALS, in which she had some respiratory potential for some weakness. And so therefore, general anesthesia with a total intravenous technique wasn't really very popular or wasn't going to be a good recommendation for her. So we wanted to do a peripheral nerve block and have it profoundly numb enough that she could have the surgical procedure. And in fact, she did, and it was an uneventful anesthetic. So avoiding general anesthesia can be a top priority in some cases. Also, less pain and suffering. We think about the prolonged analgesia that could be provided by peripheral nerve blocks. Less narcotics intraoperatively and postoperatively. If preoperative, less anesthesia and better heart rate control and blood pressure control. So if you do the block before surgery, even if you really still need to do general anesthesia, you're still going to decrease the requirements of intraoperative anesthesia and certainly some of their opioids and other agents. It's better pain control than opioids. As we all know that opioids kind of dull the senses, but it doesn't really take care of the pain. They still feel it. They just don't really care about it as much. Faster recovery and return to normal. Again, less central nervous system involvement. The patients recover faster and do well. So some about, before we get started, we have to start off with basic block safety because, above all, do no harm. And one of the major practices for us, since we are doing something that's, has laterality, we have to mark the site that we're going to block. We put our initials, the surgeon puts their initials, and we all agree, the patient agrees, any family that's present, that this is the extremity or the side we're supposed to be working on. And it's important to know that it should be visible when the patient's going to be in the position for the block. And so that's extremely important. And it should be visible after drapes. So you prep drape, you can still see your initials to make sure that you are anesthetizing the correct side. All monitors should be connected. And this is still an anesthetic. We have to place all the standard monitorings, EKG, pulse ox, blood pressure, end-tidal CO2 and oxygen. We also have suction, oxygen, and positive pressure ventilation, airway equipment around, along with medications in case we have a complication. We can treat that patient quickly and safely. We have to perform a timeout. We have to, just before we place the needle, ultrasound, we see the image that we like, or if you're getting all the stimulator stuff correct, make sure that before you start the procedure, you do a timeout and verify with someone with you in the room that you're in fact anesthetizing the appropriate location. We want to also prevent nerve damage. Several ways to do that. One is with an ultrasound. That identifies local anesthetic spread. That's a big safety. How close we are to the nerve, that we're not in the nerve. And also seeing an extravasation of local anesthetic reassures us that we're not intravascular and placing the patient at risk for local anesthetic systemic toxicity or LAST. Document patient is minimally sedated and awake. Certainly doing these under general anesthesia, that is one technique. I'm kind of more in the camp of doing these blocks when someone is minimally sedated or more awake. Nerve stimulator. So it's important to dial the nerve stimulator. Maybe you start at 1 to 1.5. Make sure you dial it down to see when your twitch disappears. And if it's less than 0.2 or 0.25, you could potentially be intraneural injection or have an intraneural injection. And we'd want to avoid that to avoid permanent nerve damage. There's a concept of opening pressure, so that initial injection, if you're intraneural, is going to be higher than 15 centimeters of water. If in fact that opening pressure is greater than that, you probably have entered the nerve. And that brings up the highlight of why you want a more awake patient, is that if you place the needle in the nerve, they're very likely, or too close, they'll likely tell you that, hey, what are you doing? I feel that, or that hurts. Or if you inject, there's going to be some pain with injection. And that's an important feature that we don't want to remove just because we prefer the patient to be more sedated or under anesthesia. And certainly in the US, to have the capabilities of having a last rescue kit with intralipids, that should be available anywhere in the hospital that you're administering boluses of local anesthetic. We have it in our facility at our block room. We also have it in our ambulatory surgery unit right across the hall from our chronic pain folks, and where we do some acute pain as well. And we also have in our obstetrical unit where we're bolusing epidurals. So again, having that availability is certainly beneficial for the treatment of local anesthetic systemic toxicity, or LAST. As you can see, this is an older slide from 2009. I think it's good enough to still use. I've been doing blocks for a long time. I would say 17 years of my 22-year career has been mostly focused on some sort of peripheral nerve block and labor epidurals and etc. So certainly many years devoted to this. You can see the surgeon's initials is the K, mine's above that. And that alerts me when I have the patient prepped and draped that I can still see those markings. And this is the recommendations for what equipment should you have immediately available for every single anesthetic, including peripheral nerve block insertions. You know, a self-inflating resuscitation bag. You know, what if the patient starts having a respiratory compromise or, again, some sort of toxicity from local anesthetic, and we have to assist their breathing or breathe for them via mask ventilation. We have to have suction tubing and catheters and all the connections. And it's really important to make sure that it actually can reach the patient, because you may not be doing these in the operating room. We perform a lot of blocks in what we call the block room, which has all this equipment ready to go. It's basically an operating room that we don't use, that we have set up for this purpose. You have to have masks of varying sizes to make sure that all the different size patients that we're going to be anesthetizing, that we have them available, various sizes of airways, oral and nasal, different size tubes and blades with handles, different size tracheal tubes, introducers. If we need a a stylet, that's a great time to have a tube ready to go and stylet it in case something happens. Invasive airway equipment, again, in case we get ourselves into a difficult airway type scenario. On top of that, we're ready to go. Supraglottic airways, multiple sizes. Lubricant that's water-based for the ease of insertion of supraglottic airways and maybe endotracheal tube. Nasal cannula and oxygen face mask. Video laryngoscopy, if that's available to you, we have that availability with necessary stylets. And that's always the key, is you have to have every single component of that equipment in order for you to be able to utilize it. ASA standard monitorings, as we mentioned before, and we should have planned and unplanned medications immediately available. And so, well, do we need non-depolarizing muscle relaxants? We're doing a peripheral nerve block. You do. If you need to emergently intubate the patient, we would need some sort of muscle relaxation and induction agent. Or if they start seizing, having a seizure from local anesthetic toxicity, we certainly would need some, anesthetics like propofol or thiopental or etomidate, something that's, whatever's available to you to treat that condition. Some more on block safety is that skin prep. We have to make sure we are puncturing the skin. We're doing an invasive procedure. We do not want an infection in the perineural area. I do mostly continuous plexus blocks, but even single injections, we have to be extremely careful that we don't take a contaminated needle and place it in the perineural environment, and someone could get an infection. So prep with either chlorhexidine, DuraPrep, or betadine. Again, I'm giving this podcast for folks, some of my students in the US, but also the Cameroonian nurse anesthetist. So if you have betadine readily available, use betadine. If you have chlorhexidine, that's a better choice. DuraPrep is kind of the second choice, but whatever's available, make sure that we do prep the skin thoroughly prior to the puncture for the peripheral nerve block. Ultrasound allows for direct visualization of not just the nerves, but also the vasculature. And I really, one of the, beginning things that you appreciate with ultrasound is that you can see the spread of local anesthetic and verify that it's not in a vein or in an artery, so you don't have intravascular injection. Anything we can do to prevent that is certainly beneficial. Minimal sedation, I talked about that, pain upon injection. We don't want permanent nerve damage because we did a peripheral nerve block. We need a nerve stimulator. Twitch electrical nerve stimulation will allow us to identify nerves and kind of verify how close the needle tip is to that nerve based on the stimulation. And again, opening pressures to have that opening pressure be less than 15 centimeters of water. And if you don't have the manometer to measure that for you, where it kind of goes up, green is good and yellow is a little close to 15 and red would be greater than 15. Just use your injection pressure as you're injecting through the syringe. You can tell if the pressure is kind of high versus if it goes in pretty easily. You would think that you're not intraneural at that point. And again, having the patient awake as well. Now we're going to discuss a little bit about the pharmacology of local anesthetics. We can see that, tetracaine started out in 1932 and bupivacaine 1963. I would say bupivacaine is still widely used worldwide as far as local anesthetics goes with peripheral nerve blocks. In the US and other areas of countries, you will see ropivacaine used a lot for its safety profile for both neurotoxicity and cardiac toxicity. But again, bupivacaine is probably still pretty popular. And so is lidocaine. Lidocaine first was popular during 1943, and certainly still used today for a lot of our peripheral nerve blocks. So what's the mechanism of action of local anesthetics? They block conduction by decreasing or preventing large transient increases in the permeability of excitable membranes to sodium, right? So we think about sodium coming in, causing depolarization. So if we can decrease that or prevent it, that large increase, or that will certainly decrease the depolarization of the membrane. The action of the local anesthetics is due to their direct interaction with the voltage-gated sodium channels. As the anesthetic action progressively develops in a nerve, the threshold for electrical excitability gradually increases, the rate of rise of this action potential declines, impulse conduction slows, and the safety factor for conduction decreases. So these factors decreases the probability of propagation of the action potential, and nerve conduction eventually fails. And so as the anesthetic action, again, as it progresses to develop in the nerve, it's going to decrease that conduction. So we think of nerve blocks as being conduction nerve blocks. Local anesthetics applied externally first must cross the membrane before they can exert their blocking action. So local anesthetics, they bind to specific sites on the inner pore of the sodium channel, creating an electrostatic field that repels positively charged ions like local anesthetic. They don't physically occlude the pores as they once thought. It's reversible binding to and inactivating those sodium channels. And so again, the open state of the sodium channel is the primary target for local anesthetic molecules. So if the sodium channel is blocked over a critical length of nerve, the propagation across the blocked area is no longer possible. And so we think about this critical length to be about 2 to 3 nodes of Ranvier. And so you kind of remember the saltatory conduction, it's jumping. And if you can block 2 to 3 of those nodes of Ranvier, if it's a myelinated nerve, you in fact have a conduction nerve block. Activated and inactivated channels they have more affinity for local anesthetic than the resting state. That's where the firing frequency kind of comes in. The more something's firing, the higher the frequency, you would have some increased affinity because you're in activated and inactivated states. But again, the open state of the sodium channel is the primary target for local anesthetic molecules. So it might be a little bit confusing with that, but in summary, this is a conduction nerve block in that we're decreasing the effects of sodium on the sodium channels, so therefore decreasing depolarization, saltatory conduction, hence a conduction nerve block results. So about 3 factors that determine the clinical differences among local anesthetics. We have all these to choose from. Let's say you have lidocaine, you have bupivacaine, and you have ropivacaine. Which one would you want to choose? The lower the pKa, that's kind of, you remember pKa is where it's 50% ionized, the pH at which 50% is unionized and 50% is ionized. And so the lower the pKa means that more unionized drug at physiologic pH, hence the onset would be faster. And so because you'd have more in the unionized fraction, and those drugs in unionized fraction would be diffused freely across lipid membranes. What about protein binding is another one. So more protein bound a medication is, or drug, has a longer duration of action because, again, remember the protein bound fraction acts like a reservoir. And then lipid solubility. Lipid solubility determines the potency of the medication. So the three factors that really affect the differences are pKa, protein binding, and lipid solubility. So about the order of a block. If you, hopefully you guys get a chance to visit NISORA's website, excellent website. They are very great with sharing their information for all folks to consume. And we think of the fibers as far as BCA, as far as the order of a block. And again, the B fibers are going to be preganglionic autonomic. They're lightly myelinated, and so they're going to be a little more susceptible to local anesthetics because they are myelinated and they are smaller. C fibers, that's going to be the dorsal root pain. They have no myelin. They're also pretty small. Postganglionic sympathetics, again, no myelin as well, but also very small, so sensitive to local anesthetics. And then A fibers. It's important to think about the order of the A fibers. And those of you who are doing spinal anesthesia and epidural anesthesia currently, you know that the patient has a decreased sensation of pain and temperature before they have a loss of motor and proprioception. And so the delta A fibers are responsible for pain and temperature. Gamma is for the muscle spindles. Think about that as like your capillary tone or the muscle tone, and that could help us with decreased blood loss with local anesthetics such as like epidurals and spinals. And beta is going to decrease, touch and pressure, and alpha is going to be your motor and proprioception. And so that's the last to be blocked. You know, if a patient's leg is, we're raising it to prep it and they don't know what position it's in, then you can be, large degree of confidence that that patient's going to be appropriately anesthetized for that procedure. Because again, they've lost sensory before they would lose the ability for motor and proprioception. And so, all right, so with epidural anesthesia, we think about order of blocks being BCA, as I discussed before. There is some, I'll go back to the other slide. There is a little bit with peripheral nerve blocks. When you look at that in NISORA, it's BAC. Again, being how they're positioned around the nerve. There's some varying studies with that, with different, did they bathe the nerve in it? And how does it respond to local anesthetic versus the placement of a peripheral nerve block. With epidural anesthesia, it's commonly thought it's BCA, and the order of the block, again, as we talked about, kind of the autonomic system being blocked first, and you see maybe a lowering of the blood pressure, and then C fibers. And essentially, as you can see how they're so close to each other, the C fibers and the A subgroups, that they're going to be pretty close as far as A deltas and C fibers being blocked together. So pain, temperature, proprioception. You have gamma fibers, beta and alpha as well, where you lose some motor function as well. So what about frequency dependent? You may hear this term. Local anesthetics gain access to receptors only when sodium channels are activated open states, and bind strongly to inactivated states. So again, firing frequency could have some effect with that. So therefore, selection conduction nerve blockade in nerve fibers by local anesthetics may be related to the nerve's characteristics of frequencies of activity, as well as the anatomical properties such as diameter. And so firing frequency seems to be the current buzz with, as we know, how it gets access and what state does it have the highest affinity. Certainly firing frequencies could promote the uptake and function of the mechanism, if you will, of local anesthetics. So pharmacokinetics, they're all weak bases with a pK value somewhat above physiologic pH. So this results in less than 50% in the unionized form at physiologic pH. So if your environment's more acidic, let's say like an infection or something like that, and you inject local anesthetic around that area, you can have even less in the unionized form. And so that would decrease the amount that's going to cross physiologic membranes, and therefore you'll get less of local anesthetic gaining access to the neurocytoplasm, and which we would need for the function of local anesthetics, especially with peripheral nerve blocks. We think if someone that has an active infection of, let's say, their ankle, and you want to do like a ankle block, certainly injecting in that infected area, you would have decrease function of your block. So going up above that, and we kind of always think of like one joint above that, the environment would be not as acidic and it'd be favorable for a peripheral nerve block. And also you wouldn't contaminate that area with your needle and bring that infection, maybe, go through an abscess or something and bring it closer to the nerve. So kind of get a dual benefit from doing that. So what about more on pharmacokinetics as far as absorption and distribution? Absorption of local anesthetics from its site of injection into the systemic circulation is influenced by a few things. And this is really important, that it's the site of injection. How well perfused is that area? If you have a lot of cardiac output going to that area, it's clearly going to take up a lot of local anesthetic and bring it to the systemic circulation. The dosage used. How much local anesthetic did you in fact inject? Did you use any vasoconstrictors like epinephrine? The pharmacologic characteristics of the drug. How much is in unionized form, and how much of it is protein bound, how lipid soluble it is. And so, when we think about pKa, protein binding, and lipid solubility, those are characteristics of the drug that is going to affect its absorption and distribution. So lipid solubility is the most important for redistribution. And basically, it's the primary determinant of potency, as we mentioned before. Protein binding influences distribution and excretion, because remember, only free drug is going to be excreted. So together, they parallel each other and are inversely related to plasma concentration. And so we want to make sure that we keep that in mind, that as we're doing peripheral nerve blocks, we're going to be in this perivascular environment. We're going to have vessels around us, and we need to make sure that we think of how much is this going to have systemic absorption. And so this is an interesting slide for what's the systemic absorption in relation to where you're injecting it. Obviously, like IV and trachea is going to be, it's highly vascular. Lots of it's going to be injected. Clearly, if you inject it in a vein, you're going to get all of it. Next would be intercostals, and then caudal blocks for epidurals, lumbar epidurals, and brachial plexus, sciatic and femoral, and subcutaneous and tumescent. That's where, they'll do that for some burn patients or some plastic surgery. And again, they're not taking up a lot because it's subcutaneously. And so certainly have a decrease uptake. So the highest is going to be obviously intravenous, then trachea, and then intercostal. And as we said before, we're going to concentrate on axillary approach to the brachial plexus, distal sciatic or popliteal, and also femoral. And so we're going to be kind of in the lower section of systemic absorption and again, enhancing the safety profile of these peripheral nerve blocks. So if you do have systemic absorption, the serum concentration, as it goes up, the symptoms are going to get a little more severe. Maybe they have just a little numbness in their tongue or around their mouth, maybe a little lightheaded. Then it's going to progress to some visual and auditory disturbances, maybe some muscular twitching, unconsciousness, seizures, convulsions, and then maybe unconscious to like coma type state, respiratory arrest, and cardiac arrest. And depending on what medications you injected, how much, you could progress very quickly from, a person feeling kind of off a little bit, not feeling very well, to having a convulsion, to, respiratory cardiopulmonary arrest. So it can happen pretty quickly, especially with intravascular injections inadvertently. And that's where we're going to spend a lot of our time with, really enhancing the safety of placing these peripheral nerve blocks. So just to review some of the local anesthetics and mechanisms of actions and pharmacodynamics, think about, when you inject esters, local anesthetics such as like cocaine, procaine, chloroprocaine, and then our amides, the lidocaine, ropivacaine, and bupivacaine. When we do a local infiltration or a peripheral nerve block, if we add a vasoconstrictor to it, as you can see all the way to the left side, is that it's basically going to decrease the perfusion to that area. And this local vasoconstriction at the site, you're going to have decreased systemic absorption of the anesthetic. You will also have a result of decreased bleeding at that site of infiltration as well. But that decrease in systemic absorption means you have decreased side effects. You can use potentially a larger volume of local anesthetics, and that will enhance your duration of anesthesia. Local anesthetics, if you increase the pH of the injected solution, and that would be adding sodium bicarbonate. If you do that, and then basically the lower the pKa of the local anesthetics and the unprotonated, unionized form local anesthetic, we know that's going to take up more of the anesthetic into the nerves and the neurons, and you have basically a shortened onset time. Also, when the molecules of tertiary amines is unprotonated, the anesthetic is lipophilic, right? And so we talked about it crossing physiologic membranes. So it's able to cross the nerve cell lipid membranes, and then the anesthetic molecule becomes protonated within the neuron. So remember, it's a little slightly less pH there. And so then when it's protonated, it's going to basically bind to that transmembrane sodium channel. So then the sodium channels become impermeable to sodium ions, preventing sodium movement across the membrane. And that's going to decrease our depolarization, nociceptive neuronal depolarization. So you get a decrease in pain sensation. And we talked about in the beginning about, smaller nerves. They have fewer sodium channels for the anesthetic to inhibit, so they're a little more sensitive. Unmyelinated anesthetic freely to diffuse anywhere along the neurons. So you end up with this differential block. What they mean by differential block is that, can you have decreased sensation with still having motor intactness? And we do this a lot. This is a very large part of my practice, is that we do a lot of peripheral nerve blocks for not just surgical procedures, but for postoperative pain relief. And we want the patients to have good motor tone. They have to be able to feel some pressure and touch, because it's very difficult to walk, for example, if you can't feel the bottom of your feet. So we want good motor intactness, but again, it also helps for them to able to feel the pressure and some touch to decrease the chance of them falling and hurting themselves. So differential blockade, very light, you're just blocking, autonomic only, versus maybe just stopping at the, the pain and temperature with the alpha subunit, sorry, the delta subunits. Sorry about that. All right, so with our local anesthetics, there's two major categories: esters versus amides. Pretty easy to tell which ones are esters as far as there's one I in the name, and amides have two I's in the name. It's important for everyone that you're going to do a peripheral nerve block for. You should say, okay, I'm using lidocaine. Is it does it have with epinephrine or without? And calculate the maximum dose in milligrams and in cc's that you can inject in this patient safely. Because, in my practice, we use a lot of low volume blocks. I would say we rarely go above 15 milliliters of local anesthetic per block, because we want to stay well below the systemic toxicity range. And so, like for example, bupivacaine, it's 3 milligrams per kilogram, regardless if it has epinephrine or no epinephrine. And same for ropivacaine. Lidocaine, it's about 4.5 milligrams per kilogram and 7 milligrams per kilogram if you have epinephrine. You can think about the duration. Why do we like bupivacaine and ropivacaine? Because of the long duration, 8 hours potentially. You're not going to have probably surgical analgesia and anesthesia for 8 hours, but you can have some post-operative anesthesia and analgesia as well. And that's probably, we've seen it last, they have analgesia post-operatively 12, 18 hours, sometimes 24 hours post-operatively. So again, we can really get some good post-op pain relief, as well as intraoperatively, either decreasing our anesthetic requirements or performing the surgical procedure under block alone. Lidocaine's roughly going to be about an hour to an hour and a half. So again, what is the maximum amount of milliliters that can be safely injected of 1% lidocaine without epinephrine when performing a peripheral nerve block on a patient that weighs 80 kilograms? So the explanation is, what's the maximum dose, milligrams per kilogram? Okay, so we're using lidocaine, so it's not with epinephrine. So we know that it's 4.5 milligrams per kilogram. If we just multiply that times their weight, that tells us the maximum amount of local anesthetic that we can give that patient. Now, if we're using 2% lidocaine, it's going to be 20 milligrams per ml. If we're using 1% lidocaine, it's going to be 10 milligrams. And so per milliliter. So if we have our patient that weighs 80 kilograms times 4.5, we can give them 360 milligrams of lidocaine to place this peripheral nerve block. Now we have to decide, are we going to use 1% or 2%? So if we're using 1%, for example, keeps the math pretty easy. 360 divided by 10, we know that we can give 36 milliliters. If we're using 2%, we only give half that. And so we're going to we have to restrict our volume to 18 milliliters of 2% lidocaine. So again, make sure you can do this, and you should do this for every single patient that you're going to perform a peripheral nerve block on. We do not want to exceed their toxicity range. And you can say, well, I've seen it done many times that way. That is very true, but we really want to promote safety, especially the availability of ultrasounds can be limited. Peripheral nerve blocks, we want to make sure that while we're getting good stimulation, you're not going to be quite as close to the nerve, so you can be tempted to give a little higher volume. It's above all, do not harm the patient. We want to stay within a safe range for these folks. All right, so what about nerve anatomy? When you think about gaining access to the nerve, we have to really appreciate, like, we want to get close to the nerve, but we don't really necessarily want to be in the nerve. We don't want to have permanent nerve damage, either from, the needle cutting or shearing the nerve, or the pressure of injection that we're basically injecting local anesthetic within the nerve fascicle, the bundle, and basically we have so much pressure within that nerve that we're not getting good, perfusion to the nerve, and so you end up with an ischemic nerve injury as well. So there's a lot of ways you can kind of damage a nerve. Breaching the epineurium and perineurium, as you can see on the slide, we like to get really close to the epineurium, but we really don't want to go inside that. And especially if you do, even accidentally, if you inject a large amount of volume in there, you could end up with some ischemic nerve injuries, because you're going to really puff that nerve up. And the patient, if they're awake, they're going to let you know, like, hey, that hurt. They'll get some paresthesia. I mean, even just brushing next to the nerve, they'll let you know that, hey, you're touching something there. But if we enter the perineurium with the needle, we're going to have permanent nerve damage. If we inject in that area, same thing. So my advice would be to just get really close to those honeycomb structures with your local anesthetic. Surround it with local anesthetic. If you have an ultrasound, if you're using nerve stimulation, we're trying to verify, like, how close are we to this epineurium. If we breach through the fascial plane, that's maybe a muscle structure that we're going through, that we're between the fascial plane and the nerve, and we're stimulating nicely, then we know that's kind of where we're at. If the stimulation doesn't go away at 0.2, we could in fact have that nerve, have the needle inside the nerve, or an intraneural injection, which would be that we're in this epineurium type place, or hopefully not in the perineurium. So that's the whole point of the nerve stimulator, to see how close we are to the nerve, but we certainly don't want to be inside the nerve. Again, I think this is super important. My students that I teach the peripheral nerve block class to here in St. Louis, we spend a lot of time discussing epineurium, perineurium, but just kind of imagine, what the stimulation would look like, or what an ultrasound image would look like if we in fact have breached the epineurium and perineurium. This is a picture of some nerve anatomy, the sciatic nerve. And we know that we have the tibial nerve and the common peroneal. And I always think of it's surrounded by this nice halo. And basically this halo, the circumneurium, is kind of the area that we'd like to bathe this whole entire area in local anesthetic. But we know that as we define, we don't want to breach this epineurium and perineurium and damage the tibial nerve or the common peroneal nerve. And we know that if we do breach the the circumneurium, we want to be very careful not to really fill this up with a ton of volume, because you could get promote some ischemia. And so really just bathing the local all around this, where it kind of looks like a halo, that's a great block. Just to reemphasize about the epineurium and perineurium, think about the fascicles, how we don't want to damage those either directly with the needle or indirectly with the pressure that we're injecting and decreasing some perfusion. When we think about saltatory conduction, as far as jumping from the nose or unva, you can see those noted here as well. Again, we want local anesthetic to gain access to this area. I'm not sure we really want to inject in that area and cause damage. So we're going to pause here, and I will take a moment for us to take a little break, and then we'll come back and discuss the various techniques of peripheral nerve blocks.